of you here do joint replacement as an outpatient? Go home same day. How many of you do that? How many of you would like to be doing that? There you go. So you have to round in the hospital things. So we had an unusual situation with COVID, of course, in the United States, because prior to COVID, about 1% of our arthroplasties were done as an outpatient. But we had to figure out how to not get people in the hospital, but still take care of their issues with their knee pain. So we worked with pain management and anesthesia providers, our home health providers, and the families to develop strategies so we can start doing our arthroplasties as an outpatient. And currently about half of our primary joint replacements in the United States now are done as an outpatient, at least in our area. So the way you do that, it's all about expectation for the patients and preparation. You guys have a huge head start already because you guys don't use narcotics in the perioperative period. In the United States, we really have a high demand for narcotic use, so we had to balance that with all of our pain management strategies along the way. So we made sure we had the right patients, established protocols, and we had to get the anesthesia people to buy in, and meticulous surgical technique, which you guys already have experienced some of that today. That's unbelievable. Great job. And we had to make sure that the home care is optimized, because otherwise patients go home and they bounce back. So it's all about the preparation. So the preoperative considerations, we want to make sure that you have the right candidate, stable health, good home situation, so they have good home support, access to adequate resources, home health for physical therapy for somebody to keep a look at them, family and friend support so somebody can stay with them, and that they need to have adequate transportation in the event that they need to get back to you for their follow-ups, etc. So the other considerations, of course, are to make sure that we have their proper medical evaluations, and we want to make sure that they acquire the appropriate labs, reviews, and have those things addressed prior to the surgical procedure themselves, and arrange for their medications at home, whatever you're using for their perioperative pain control. Make sure the home health is arranged, their physical therapy, their follow-up, and verify that it actually occurred. You just can't just trust that it happened, of course. So the special considerations, of course, you want to update the oral health. We were pleased today to see that most of the patients who come in for joint replacement here, of course, have dental evaluations prior to, and we do the same thing in the U.S. Because we know that a lot of the post-operative infections actually come from oral health issues. Make sure the coexisting health threats like DVT screenings, make sure they don't have coexisting urinary tract or pneumonias, make sure any other infectious sources are developed. And if you have enough time, we do like to have weight loss so that they just have less demand on the joint afterward, and also the other things that are associated with obesity, which has already been addressed here at the conference. So we try to time the surgery to minimize the effects of coexisting therapies like chemotherapy. We talked about the rheumatoid arthritis people and DMARDs. We try to position our operative techniques between their doses of either chemotherapy or the DMARDs in order to minimize the post-operative infectious risk. One of the other things we do in the preoperative area is we do have a program where we can do cryotherapy or radiofrequency ablation of the periarticular geniculate nerves, so their post-operative pain is managed very, very well. We also do adductor canal blocks with long-acting drugs such as Exparel, and intra-articular medication as well. I don't know if you guys have a Zen Relief here, but that's a long-acting intra-articular placement of a honey-type gel, which gives people 2 days of pain relief post-operatively. Anti-inflammatories, we tend to use COX-2 inhibitors so it doesn't mess up their platelets along the way post-operatively, so it has much wound drainage. And we use gabapentin in the perioperative period, both pre-op and post-op. The last preoperative consideration, I hope you guys are recognizing almost all this talks about pre-op. If you walk in with the right expectations, proper preoperative expectations, preoperative evaluations and care, most of the post-op stuff just take care of itself because you guys are already doing that. So we educate the patients, make sure they know what to expect. In-office educators, joint classes are done at a hospital. And talking to Dr. Shah last night, I found out that you guys use perioperative counselors, people who do psychologists working with the patients for expectations and pain management. Because I do think that for a lot of these people with chronic pain, of course, we know that a lot of them are depressed. So we'll deal with that. So intraoperative considerations. Well, meticulous hemostasis along the way. If they're not bleeding intraoperatively and postoperatively, they're less likely to have a wound disruptive problem or a swollen leg to the point they have a difficult time getting over the pain. We try to err on the side of doing less. If you don't have to take out hardware, don't take out extra hardware. If you can get away without doing osteotomies, don't do the osteotomies. Fewer build-up blocks, fewer stems. Those things will just lead to better postoperative recoveries as an outpatient. We do open wound analgesia, we do periarticular injections, and of course, we talked about Exparel a while ago, which is a lysosomal bupivacaine, but also just bupivacaine injections with epinephrine, so you get lasting results from that. And the intra-articular medications, the only one available to us right now is really Zenrelief, but I think there's others available. So at the very end of the procedure, we want to make sure that we apply dressings that are both patient and attendant friendly. We use silver ion impregnated and water-resistant dressings and apply gentle compression wraps. So if possible, use a stockinette, a pressure stockinette below the knee, and then maybe a light ACE wrap over the knee, just to minimize the postoperative swelling and bleeding for hemostasis. And they're already into postoperative considerations, some of which we've already mentioned. Make sure you have good home support. You have to determine that preoperative and verify they're actually going to be with the patient and understanding their roles like that. Have a pain management plan in place so the patient knows it ahead of time, and anticoagulation only based on risk stratification. Kind of less is more as long as you're not putting the patient at risk for having a postoperative blood clot, which will bring them back. So home health, where it's available, is of course key for physical therapy, and in our case, we use it for nursing care to keep a track of the patient, the wounds, make sure they're getting their medications on time. The reasons we would use an knee immobilizer is for weight-bearing activities to make sure they don't have the leg collapse, because above all things, we want to make sure that patients do not have a fall at home. And we do like to get early motion, early weight-bearing, but only if it's protected. And make sure the patient and support person know how easily to get in touch with the office, because that'll bring them back to the ER in cases where you don't want. But they can get in touch with, most of the people they have anxiety and they just want to make sure they get reassurance. So we make sure they can get in touch with us very easily. Most of these surgical procedures done here, I think, don't have staples. That's great, so I don't have anything to remove, but we use mostly staples because that's our standard of care. So we bring them back to the office about 13 days after surgery to remove those staples. We want to make sure that they have wound closure problems, so it's going to be very tight, watertight along the way. But it comes down to the preoperative phase is the most important. It's also the most time and energy consuming. But the importance of education, setting expectations cannot be overstated. If somebody's expecting to go home, we want to make sure that they know their roles and their family knows their roles. It can be cost effective and it's very time efficient, because then you're not rounding on the patients the next day and spending more care with them that way. And the patients, as long as they can get back in touch with you, they're good enough. Thank you very much.